So for this supplemental session in biochemistry, we're going to take up heme metabolism. I'm going to show you an approach wherein basic biochemistry will actually extend or cross over to several other subjects, such as pathology, medicine, as well as pharmacology. So for a disclosure, this is not yet the official lectures for the full course session. These are just supplements to keep you guys busy during this period of quarantine. Now, our topic for today will be heme metabolism. So we will talk about heme, hemoglobin, bilirubin synthesis, and all of the medical and clinical as well as pharmacological correlations of this biochemistry basic. Now, these are the official references that I'll be using. So we have number one, the 31st edition of Harper's Biochemistry. Then I'm also giving supplements from your Robbins Pathologic Basis of Disease 9th edition. This is the chapter where I'll be lifting majority of the topics from. This is chapter 6 on your proteins, which is myoglobin and hemoglobin. Our focus will be on hemoglobin. Now, first, let me introduce the concept of globular proteins. Okay, the concept of globular proteins. Now, in biochemistry, there are two globular proteins you have to remember. And what are these two globular proteins? We have myoglobin, then we have hemoglobin. Our focus today will be hemoglobin. So to remind everyone, you have two very important globular proteins, which is hemoglobin. Then we have myoglobin. Now, please remember, between myoglobin and hemoglobin, both will contain heme. So I would like to repeat, both hemoglobin and myoglobin contain heme. So both globular proteins have heme in its structure. Now here, let me remove this first. Okay, there. This is lifted from your Harper's, showing you the biochemical structure of heme. Now, the good thing is you don't have to memorize it. However, I want everyone to remember the following. So number one, we have the Pyrrole rings, and we have the iron or the Fe2, which is found there. So please take note of this. So we have the Pyrrole rings, then we have iron. So if you are asked in any basic examination, what are the two important structures which comprises heme? Number one is the Pyrrole ring. Number two is your iron, your Fe2. Now, between myoglobin and hemoglobin, always remember it is only myoglobin that exhibits a tertiary structure. So I would like to repeat, it is only myoglobin that exhibits a tertiary structure. Now, let's go back to basics. When we talk about proteins, proteins have four levels of structure. We have primary, we have secondary, we have tertiary, then we have quaternary or quaternary. So again, what are the four levels of protein structure? We have primary, secondary, tertiary, then we have your quaternary. Now, always remember the primary level of structure of proteins. Again, the primary level structure of proteins is represented by your peptide chain. So letter P for primary. Letter P for primary is the peptide chain. The secondary structure. Then we have the tertiary structure, which is represented by your domains. And the classic example of a tertiary structure would be myoglobin, while the classic example of a quaternary structure would be hemoglobin. Now, this is lifted verbatim from your textbook. Myoglobin is a polypeptide. You don't have to measure the values, but this is what you have to remember. About 75% of the residues of myoglobin, again, about 75% of the residues of myoglobin are present in 8 right-handed residue alpha helices. Now, don't forget, an alpha helix is actually an example of a secondary structure of protein. However, myoglobin is more complex than that, and the textbook states myoglobin is a tertiary structure. So alpha helix, beta pleated sheets are all secondary structures. So alpha helix and beta pleated sheets are secondary structures, while myoglobin consists of 8 alpha helices. It is tertiary. Now, myoglobin, okay, when we talk about the biochemical structure of myoglobin, okay, your alpha helices, okay, will be labeled from letter A to H. Since there are 8 alpha helices, it is labeled as helices A, B, C, D, E, F, G, and H. Now here, this is lifted from your textbook. The 3-dimensional structure of myoglobin. The 3-dimensional structure of myoglobin, okay? So if you notice there, there's letters, there's A, B, C, D, E, F, G, and H. So as you notice, there are 8 helices, or 8 alpha helices, or helix, the helices in your myoglobin. So this is the 3-dimensional structure of your myoglobin. Now, please remember, myoglobin is the major globular protein which is found in 2 types of muscles. We have the cardiac, then we have the skeletal muscle. We have the cardiac, then we have the skeletal muscle. Okay, so myoglobin is found in both the cardiac and the skeletal muscle. Now, myoglobin is also considered to be the reservoir of oxygen. Most of our oxygen is bound to hemoglobin. Myoglobin serves as the reservoir of oxygen. And please take note, we now zoom in to the bulk of tonight's talk, which is hemoglobin. I want you to remember, hemoglobin consists of 2 structures. The first is your globin, which is the protein portion. The second is your heme, which is your iron-carrying portion. Now, trust me, in the board exams, hemoglobin will not only come out in biochemistry, it should come out in physiology, pathology, as well as your medicine. So hemoglobin consists of heme and globin. So heme is the iron-carrying portion, and globin is the protein portion. So if you remember earlier, we mentioned the biochemical structure. We mentioned the biochemical structure of your heme, wherein it has a Pyrrole ring and it contains iron. Now, memorize this by heart. So we have several types of hemoglobin. One is the adult hemoglobin. We also have the fetal hemoglobin. Now, the adult hemoglobin, this is a must know. The adult hemoglobin, or what we call HbA, so A for adult, consists of alpha and beta chains. There are 2 alpha and 2 beta chains. 2 alpha and 2 beta chains. So please take note of that. Now, please remember, diseases which involved hemoglobin are what we classify as hemoglobinopathies. So diseases that involve hemoglobin are classified as hemoglobinopathies. And when we have blood disorders which specifically affects the chains of hemoglobin, this is what we call the thalassemias. So if it affects the alpha chain, this is an alpha thalassemia. If it affects the beta chain, this is a beta thalassemia. So your hemoglobin disorders are called hemoglobinopathies. If the specific pathophysiology or etiology involves either the alpha or the beta chain, then this is what we call thalassemias. Now, this is lifted from our mother textbook. So this is how hemoglobin looks. Now, just recap. We showed you the picture in Harper's of myoglobin. Myoglobin is a tertiary globular protein, and it has how many alpha helices? It is 8 alpha helices, which is labeled as A, letter A up to letter H. Hemoglobin, on the other hand, is a quaternary protein structure. It is a quaternary protein structure which contains your heme. And always remember, right in the middle of your heme molecule is your iron. And the hemoglobin molecule, the adult hemoglobin molecule, has how many beta chains? It's 2. So 2 beta chains. How many alpha chains? 2. So it's 2 alpha and 2 beta. Now, always remember this physiologic as well as biochemistry principle that it is hemoglobin which is capable of binding 4 molecules of oxygen at a time. 4 molecules of oxygen at a time. So please don't forget, hemoglobin, which is a globular protein, can bind 4 molecules of oxygen at a time. Now, always remember this. There are actually 2 very important factors or variables that affects the binding of oxygen, okay, to your hemoglobin. And this is number 1, the pH. Number 2 is the carbon dioxide concentration. So what affects the binding of oxygen to hemoglobin? Number 1 is the pH. Number 2 is the carbon dioxide concentration. Now, for biochemistry and physiologic purposes, your hemoglobin exists in two forms. Now, always remember this principle for exams. What are the two forms of hemoglobin? Number one is the taut, that's letter T, and the relaxed form, which is letter R. Now, I would like to remind everyone that the taut or the tout is what other biochemistry references refer to as the letter T, the tense form. So the taut or the tense form refers to the same form of hemoglobin. The second form of hemoglobin is the R form or the relaxed form. Now, always remember, between the taut and the relaxed form, it is the relaxed form that can readily bind oxygen. Okay, so the binding of oxygen is easier when hemoglobin is in the relaxed form. Now, I hope you're familiar with this. Okay, the famous sigmoidal oxygen hemoglobin dissociation curve. Now, most references call it the oxygen dissociation curve, but my friendly tip to you is memorize the phrase oxygen hemoglobin dissociation curve, or hemoglobin oxygen dissociation curve. I'll show you how it looks, and it is sigmoidal in shape. Now, let us quickly go over the following physiologic and biochemical reactions of hemoglobin. Number one, we have oxyhemoglobin, which is HbO2. Once hemoglobin binds with oxygen, so once hemoglobin binds with oxygen, this is now known as oxyhemoglobin. So that's not too hard to memorize. So once oxygen, okay, and hemoglobin bind, what compound is formed? Oxyhemoglobin. Now, always remember, when oxygen and hemoglobin bind, it is characterized as a loose and reversible type of binding. A loose and reversible type of binding. And it is oxyhemoglobin which transports oxygen from the lungs to the tissues. Okay? So it binds, and it's characterized to be loose and reversible. And take note, oxyhemoglobin transports oxygen from the lungs to the tissues. Okay? Now, please memorize this by heart. Now, this oxygen hemoglobin curve that I'm showing you is actually lifted from our Byrne and Levy physiology because it has a better illustration, in my opinion, compared to the illustration in our biochemistry textbook. So on the left, you have the hemoglobin saturation. So that's from 0 all the way to 100%. Then on the other axis, we have the partial pressure of oxygen below, which is from 0, 20, 40, 60, 80, and 100. And the unit is millimeters mercury, or mmHg. Hemoglobin saturation, the unit is percent. Now, always remember this dictum. In the examination, they're always going to ask you, either it's a toss-up between physiology or biochemistry. They're going to ask you, what are the factors that causes a shift to the right or a shift to the left of this sigmoidal oxygen hemoglobin curve? Now, I want everyone to remember, the oxygen hemoglobin curve will shift to the right whenever there are conditions wherein oxygen saturation is low. Again, conditions wherein oxygen is low, kulang, hindi siya sapat. When there is lacking oxygen, the curve will shift to the right such that more oxygen is made readily available to the peripheral tissues. Again, conditions, okay, conditions wherein oxygen is lacking. This will cause the curve to shift to the right so that more oxygen is made readily available for the peripheral tissues. Now, if you look at this graph, it says there, these conditions, which causes a shift to the right. So on your right side, we have increased temperature, increase partial carbon dioxide, increase in your 2,3 diphosphoglycerate. So DPG is diphosphoglycerate. And don't forget other physiology and biochemistry references. Call it BPG, which is biphosphoglycerate. Then we have a decrease in the pH. Now, if you notice the shift to the left, which is on your upper left, the shift to the left is caused by conditions wherein oxygen is enough and there is increased affinity. And this would be the opposite: decreased temperature, decreased PCO2, decreased 2,3 BPG, and increased pH. Now, friendly tip, do not memorize both. I'm going to give you a heads up, examination purposes. What is more important, physiologically and biochemically, is going to be the factors or conditions that causes a shift to the right. So I strongly encourage you to memorize those. Now, in addition to that, memorize what's in the yellow box. Okay, so increase P50, decreased affinity. So whenever there's decreased affinity or conditions where oxygen is not adequate, the curve will shift to the right such that more oxygen is made readily available to your peripheral tissues. So one more time, increased temperature, okay, hyperthermia, increased PCO2, we have increased 2,3 DPG, which I'll explain later, and decrease in pH. So here, factors that lower oxygen binding to hemoglobin. Now, if you notice, for memorization purposes, everything is increased except the pH. So my heads up, examiners love to change the direction of the arrow, whether it's going to be increase or decrease. That's why I highlighted that in red. Now, let's take note of this reminder. The most abundant form, okay, the most abundant form of hemoglobin in adults, letter A for adults, is hemoglobin A. Now, there is another form of hemoglobin which is formed with the non-enzymatic addition of glucose. So non-enzymatic addition of glucose to hemoglobin gives you hemoglobin A1C. Memorize this by heart. Now, what is the clinical significance of your hemoglobin A1C? This is a laboratory test which is now included for the diagnostic criteria for diabetes mellitus. It is used to determine the glucose control of diabetes mellitus. So it will more or less give you an idea of the glucose control for the past 3 months. So 3 months, that's about 90 days, okay? Glucose control for the past 3 months. Now, please zoom into this. The transport of carbon dioxide in the blood, okay? Now, always remember this principle. Physiology, biochemistry. The major transport form of carbon dioxide in the blood is in the form of bicarbonate. So the major transport form of carbon dioxide in the blood is bicarbonate. And always remember this, bicarbonate is the major buffer in our body. Okay, bicarbonate is the major buffer in our body. So when carbon dioxide will now bind with hemoglobin, you now form carbaminohemoglobin. So when carbon dioxide binds with hemoglobin, you now form carbaminohemoglobin. So let's recap. What compound is formed when hemoglobin binds with oxygen? It's oxyhemoglobin. And what compound is formed when hemoglobin binds with carbon dioxide? It now becomes carbaminohemoglobin. So what about when carbon monoxide binds with hemoglobin? Then what you form is carboxyhemoglobin. So when carbon monoxide binds with hemoglobin, you form carboxyhemoglobin. When carbon dioxide binds with hemoglobin, you form carbaminohemoglobin. Now, please remember this flashcard. Carbon monoxide binds tightly but reversibly to the hemoglobin iron. So this is carboxyhemoglobin. So please take note of this. Now, another form of hemoglobin is your methemoglobin. Now, methemoglobin is formed whenever iron is oxidized by nitrates and other certain compounds. So oxidation of iron, okay? So methemoglobin is produced when iron is oxidized by nitrates. This oxidized iron will accumulate in the skin and it will give you the dusky discoloration of the skin. Okay, the dusky discoloration of the skin. Now, oxidation of the heme component of hemoglobin to Fe3, okay, will now give you methemoglobin. And please take note, methemoglobin, okay, will not be able to bind oxygen. Now, we're going to take a 5-minute break to stretch. Okay, so take a 5-minute break to stretch. You can stand up, take a break. Okay, we'll resume in 5 minutes. Okay, so let's resume. Let's talk about carboxyhemoglobin. So we mentioned that when hemoglobin binds with carbon monoxide, it now becomes carboxyhemoglobin. And always remember that carbon monoxide has higher affinity than oxygen. I think most references would say carbon monoxide has about 200 to 300 times higher affinity than oxygen. Now let's mention cyanosis. which is defined as the dark blue discoloration of the skin, and this is usually associated with anoxia or the absence of oxygen. So the dark blue discoloration of skin associated with anoxia is cyanosis. Now, usually, cyanosis becomes evident when the concentrations of reduced hemoglobin exceeds 5 grams per dl. So cyanosis can be caused by chronic hypoxemia. So the most common cause of congenital cyanosis, this is a perfect question in any exam, is still your tetralogy of Fallot. The most common cause of congenital cyanosis in the neonatal period is tetralogy of Fallot. So patients with long-standing valvular heart disease or long-standing congenital heart disease can present with cyanosis. Now, flashcard, we know this is going to come out. What do you call the phenomenon associated with the unloading of carbon dioxide secondary to increased oxygen? What do you call the phenomenon associated with the unloading of carbon dioxide secondary to increased oxygen? So the magic word to memorize here is unloading of carbon dioxide. So what do you call the phenomenon associated with the unloading of carbon dioxide secondary to increased oxygen? This is the famous Haldane effect. So please memorize Haldane effect, okay? So please take note of this. Now, we mentioned earlier, okay, the transport of carbon dioxide in the blood is in the form of bicarbonate. And the most important enzyme, which is needed for the transport of carbon dioxide in the blood, is your carbonic anhydrase. Okay, your carbonic anhydrase. Now, Haldane effect, the release of carbon dioxide when oxygen binds with hemoglobin. The release of carbon dioxide when oxygen binds with hemoglobin. Now, what do you call the phenomenon associated with unloading of oxygen secondary to increased hydrogen concentration? What do you call the phenomenon associated with unloading of oxygen secondary to increase hydrogen concentration? This is now the Bohr effect. So unloading of carbon dioxide, Haldane effect, then we now have the Bohr effect. Okay, now we mentioned earlier that adult hemoglobin has 2 alpha and it has 2 beta chains. Now, fetal hemoglobin is also a tetramer, so that means there's 4 chains, and it consists of 2 alpha and 2 gamma chains. 2 alpha chains, 2 gamma. So adult hemoglobin, HbA, is 2 alpha and 2 beta, while HbF, or fetal hemoglobin, is 2 alpha and 2 gamma. Now, what is this abnormal condition wherein instead of having 2 gamma chains, there are now 4 gamma chains? So gamma tetramers in the newborn, this is your hemoglobin BARTs. So this is associated with hydrops fetalis. So gamma tetramers in the newborn, so that means instead of having only 2 gamma chains, it's now going to be 4. And this condition is known as hemoglobin BARTs. This is associated with hydrops fetalis. And hydrops fetalis is associated with the virus Epstein-Barr virus, as well as your parvovirus. but most references would highlight the parvovirus. And that would be my answer in an exam. Now here, if you zoom in to this illustration, showing you hemoglobin, quaternary structure. There's the beta globin chain on top, okay, the green and the yellow. And we have that purple and the blue, the two alpha chains. So adult hemoglobin is 2 beta, 2 alpha. If you notice, the iron atom is right in the middle of your heme molecule. So here, so take note of this. So the globin, 2 alpha, 2 beta chains, which are mainly helical. And you have your different types of hemoglobin: hemoglobin F, hemoglobin A, hemoglobin C, and hemoglobin E. So your mnemonics there is actually the word face: hemoglobin F, A, C, and E. Now, let's zoom in to a pathway, okay? Your heme and your porphyrin synthesis. Now, if you remember in previous videos, we talked about the site of metabolism, and we mentioned that the pathways, the biochemical pathways that occur both in the cytosol and mitochondria is HUG, H-U-G, heme, urea, and your gluconeogenesis. So heme or porphyrin synthesis, where's the site of metabolism? The cytosol and the mitochondria. Okay, so let's zoom into heme or porphyrin synthesis. Now, let's mention this. Now, I'll be honest, I don't like this illustration, but this is the official illustration which is found in your Harper's. So one of the reasons I don't like this is because the pathway starts at the bottom. Look at number 1. Okay, everyone zoom into your screen. Look at number 1. This is the start of heme or porphyrin synthesis. It starts with succinyl-CoA plus glycine. Memorize that. Succinyl-CoA plus glycine. Okay, succinyl-CoA plus glycine will become your amino-levolinate acid, or your ALA. And the enzyme is ALA synthase. Now, I'm going to dissect this. Don't be scared. So everyone zoom in to the bottom. Succinyl-CoA plus glycine. That is the start of heme synthesis. Now zoom into the topmost. You now have heme. Once heme binds with a protein, then it is now known as a hemoprotein. Okay, so no need to rush. Now let's zoom into this. Okay, I hope that's much better. So zoom into succinyl-CoA. Okay, succinyl-CoA. Take note of that. There. Succinyl-CoA plus the amino acid glycine will become ALA. Memorize step number 1 by heart, because if there is a question regarding heme synthesis, it's most likely going to be step number 1, which is the rate-limiting step. And the rate-limiting enzyme is ALA synthase. Now, ALA will now be converted to become PBG. What is PBG? This is Porphobilinogen. And the enzyme here involved is ALA dehydratase. Now, let's stop here. Succinyl-CoA plus the amino acid glycine with the action of ALA synthase will now become ALA, and ALA will now be converted to PBG or Porphobilinogen through the enzymatic action of ALA dehydratase. Now, please remember this. ALA dehydratase is the enzyme which is inhibited when there is lead poisoning. Again, what is the enzyme which is inhibited in lead poisoning? It's ALA dehydratase. Now, so let's start. We have ALA PBG or Porphobilinogen. Porphobilinogen will further be converted to hydroxymethylbilane. The enzyme here is your Uroporphyrinogen synthase 1. Hydroxybilane, okay, take note, hydroxybilane will now be converted to your UPG, or your Uroporphyrinogen 3. The enzyme is Uroporphyrinogen 3 synthase. Now, tip, if a question's going to come out in a standard biochemistry exam, it's most likely going to involve enzyme number 1, which is allosynthetase, and enzyme number 2, which is aldehydrate. Okay, now zoom in and memorize this. Glycine plus succinyl-CoA becomes ALA. The enzyme is allosynthetase. This is the rate-limiting step, the most important step in heme synthesis. And please take note, allosynthetase is the rate-limiting enzyme. Okay. Every time someone wants to get in, the screen share is disrupted, okay? Now, memorize this by heart. Heme is synthesized where? Okay, so please take note. Heme is synthesized in what sites of metabolism? So heme is synthesized, okay, in the mitochondria and the cytosol. And don't forget, step number 1 involves what 2 substances? So it involves succinyl-CoA and glycine. Now, don't forget, rate-limiting enzyme, take note, rate-limiting enzyme is allosynthetase. Do not take the boards if you don't know this. Now, I lifted this verbatim from your Harper's. So it says here, heme is synthesized from succinyl-CoA and glycine. Now, I just want everyone to remember what ALA is. So ALA stands for alpha amino livolynate. ALA, A-L-A, is alpha amino livolynate. And please don't forget the synthesis of ALA. That's step number 1. This occurs in the mitochondria. Okay, step number 1 in heme synthesis, which is the synthesis of ALA, occurs in the mitochondria. Now, please remember this. There is a cofactor which is needed to activate glycine, and this cofactor is pyridoxal phosphate. Again, this cofactor is pyridoxal phosphate. So please take note, pyridoxal phosphate is the coenzyme, okay, cofactor, which comes from vitamin B6 or pyridoxine. Now here, going back to that very busy illustration from Harper's Biochemistry, okay? So we mentioned alpha amino livolynate, or your ALA. So memorize this. That's your allosynthetase, the rate-limiting enzyme. Okay. So I want you guys to zoom into this. Now take a deep breath, slow down, review this. Okay, and this is your famous PBG, or Porphobilinogen. Okay, Now here, so let me mention this. Okay, memorize this by heart. Porphobilinogen, or PBG or PGB, becomes hydroxymethylbilane. The enzyme involved is PGB deaminase. Now, why am I highlighting this? Because deficiency of PGB deaminase leads to what clinical condition? It leads to acute intermittent porphyria. So deficiency in PGB deaminase leads to acute intermittent porphyria. Okay, so this is the enzyme PGB deaminase. Disease, acute intermittent porphyria. Now that we have hydroxymethylbilane, I'm going to go straight to the shortcut because this is the only thing you have to memorize. You will now have heme. Okay, now two terminologies which I want to mention, which is highlighted in bold in your textbook. One is uroporphyrin. Uroporphyrin is the most water-soluble porphyrin. The most water-soluble porphyrin is uroporphyrin, while protoporphyrin is the least water-soluble porphyrin. So the least water-soluble porphyrin is protoporphyrin. Now, here, zoom into this. Okay, I want everyone to look at the numbers. So number 1, okay, everyone zoom into number 1. This is the rate limiting step where ALA synthase or aminolivolinate synthase comes in. Look at step number 2. Okay, that's lead poisoning. Okay, that's your dehydratase. Look at step number 3. Okay, which is your porphobilinogen deaminase. PBG deaminase, what's the condition? Acute intermittent porphyria. Now, there is a condition, okay, look at number 5, wherein you have a deficiency in your uroporphyrinogen decarboxylase. And this leads to the condition known as Porphyria, Cutanea, Tarda. Porphyria, Cutanea, Tarda, PCT. Lead poisoning can also block your ferrochelatase, which is number 7. So the two enzymes inhibited by lead poisoning. What are the two enzymes inhibited by lead poisoning? So first we have aminolivolinate dehydratase or ALA dehydratase. Then we have ferrochelatase, your number 7. Number 2, then we have number 7. Okay. So we showed this earlier. Okay, now clinical. I got this from medicalinstitution.com. Okay, most reviewers will only say 5 P's, but take note, there's actually 6. So first, porphobilinogen deaminase deficiency. The next P is pain, pain in the abdomen. Now, always remember this. The most common manifestation, which occurs in about 90 to 95% of patients, is actually abdominal pain. There's also psychological symptoms, which includes hallucinations, depression, delirium, hysteria, as well as agitation. There's also peripheral neuropathy. Okay, so that means the patient will present with numbness. The patient will also present with paresthesias. There's also peeing abnormalities. So that means the patient complains of dysuria. The patient has dark urine. The patient can also present with urinary incontinence or urinary retention. And it is P, precipitated by drugs. Particularly, number 1 on the list is barbiturates. Next is oral contraceptives. Third is sulfonamide drugs or sulfa drugs. Now, board exam purposes, memorize barbiturates, memorize your sulfa drugs. Okay? So zoom into this. Okay, let's proceed. So here, drugs associated with acute intermittent porphyria. Now there's a lot of drugs here, but friendly tips. Just memorize your barbiturates and your sulfamethoxazole. Okay, memorize barbiturates, memorize sulfamethoxazole, your sulfonamides. So always remember this dictum. Barbiturates and sulfonamides are contraindicated in patients with porphyria. And they are also contraindicated in patients, okay, who have electron transport chain problems, because barbiturates will inhibit your electron transport chain. Now, I'd like to add also that antimalarials can also exacerbate porphyria. So memorize barbiturates, memorize sulfamethoxazole or sulfonamides. Now here, the classification of porphyrias. So this is no longer well discussed in your biochemistry reference, so let's go a little clinical. So porphyrias can either be classified as acute, cutaneous, or a combination of both acute and cutaneous. Now under acute, so we have AIP, that's acute intermittent porphyria. We have your plumbo. Plumbo means iron. Okay, so plumboporphyria or your DOS porphyria. This is because of a deficiency of your ALA dehydratase. And for the cutaneous, so by the word cutaneous, it means the patient presents with dermatologic or skin manifestations. Number one on the list, and to tell you the truth, this is the only one you have to memorize, PCT or Porphyria cutanea tarda. Just to mention in passing, we have congenital erythropoietic porphyria, erythropoietic protoporphyria, and hepatoerythropoietic porphyria. So what should you memorize? Porphyria cutanea tarda, or PCT. Now, a combination of both acute and cutaneous, we have hereditary coproporphyria and variegate porphyria. Doc, I only have 2 neurons left. What should I memorize? Memorize AIP, memorize Porphyria cutanea tarda, and if you have an extra neuron, memorize the ALA dehydratase deficiency, with special emphasis on acute intermittent porphyria and your Porphyria cutanea tarda. Now here, this is borrowed from the Academic Dermatology of Nevada Atlas. So zoom in to these blisters that you see. Okay, so this is Porphyria cutanea tarda. They usually present with painless, okay, painless blisters on the sun-exposed areas. They also present with photosensitivity. And there's also going to be sort of darkening of the skin, which is hemochromatosis. So this is because of iron breakdown, which now accumulates in different organs, particularly the liver. Next would be the skin and also the brain. Here's another picture of the blisters. Okay. Porphyria cutanea tarda. Now here, zoom in, you notice these 2 patients are quite hairy. So there's hypertrichosis or excess facial hairs. So memorize these 3 manifestations of Porphyria cutanea tarda. Number 1 is photosensitivity. Number 2 is painless blisters. Number 3 is hypertrichosis. Photosensitivity, painless blisters, then hypertrichosis. Okay. Now this is bilirubin metabolism. So the breakdown of our red blood cells, the RBCs. So please take note, the major organ involved in the breakdown of RBCs is the spleen. The spleen is the graveyard It is the graveyard of our senescent or old red blood cells. I hope everyone still remembers the usual lifespan of the RBC is 120 days. Once the RBC reaches 120 days or near 120 days, this old RBCs will now undergo hemolysis. They will be sequestered in the spleen, and the red blood cell will be broken down into hemoglobin. Hemoglobin, as we mentioned earlier, has two portions. What are these two portions? The iron and the globin portion. Now, hemoglobin is broken down into biliverdin. The enzyme is heme oxygenase. Biliverdin is further metabolized to bilirubin, and the enzyme is biliverdin reductase. Bilirubin binds to albumin, and what is formed when bilirubin binds to the protein albumin is your bilirubin-albumin complex. Now, this bilirubin-albumin complex will undergo further metabolism by the action of the enzyme glucuronyl transferase, thus converting bilirubin or conjugating bilirubin. Now, please don't forget this binding of bilirubin and albumin, okay, this complex, it goes through the enterohepatic circulation, and don't forget the liver is the site for your conjugation. So conjugated bilirubin undergoes one more step, which is called glucuronidation. So the enzyme for glucuronidation is your beta glucuronidase. We now form urobilinogen. Urobilinogen can be passed through the stools, and this will be in the form of stercobilin. And this will give our stools a characteristic color. Urobilinogen will now be brought to the kidneys, and it will come out of the urine as urobilinogen. Now let's zoom in. Okay, so whenever you have a pathway, you read the entire pathway first, then you try to dissect. So what I did was I went straight to hemoglobin. Hemoglobin is converted to biliverdin. Memorize this. This always comes out in exams. So hemoglobin is metabolized or converted to biliverdin. What's the enzyme responsible? It is heme oxygenase. So please memorize this. Now, biliverdin will be reduced and it will become bilirubin. What's the enzyme? Biliverdin reductase. Now, bilirubin will undergo conjugation, and this enzyme, UDP glucuronyl transferase, please memorize this. UDP glucuronyl transferase. So once bilirubin is conjugated, it now becomes bilirubin diglucuronide. So bilirubin undergoes conjugation in the liver, major enzyme, UDP glucuronyl transferase. And bilirubin will now be conjugated and it undergoes glucuronidation. So it now becomes bilirubin diglucuronide. Now, cross over to pharmacology. The enzyme UDP glucuronyl transferase. Now, this enzyme is found in the liver. So if you have a preterm baby, the liver is still immature, so it's going to lack enzymes, and one of the enzymes that might lack is your UDP glucuronyl transferase. So what is now the pharmacologic and clinical crossover here? There is a drug called chloramphenicol. Okay, everyone, memorize and jot down chloramphenicol. The antibiotic chloramphenicol causes a condition known as gray baby syndrome. And the enzyme involved here is your UDP, glucuronyl transferase. So gray baby syndrome caused by what drug? Chloramphenicol. Now, memorize this. This will come out in standard exams. Okay, this will come out in standard exams. Now, what enzyme will conjugate unconjugated bilirubin? It is uridine glucuronyl transferase. Uridine glucuronyl transferase. Okay, memorize this, the enzyme that will conjugate unconjugated bilirubin. Now, let's mention these terms direct and indirect bilirubin. Let's start with direct bilirubin. Direct bilirubin is also known as your conjugated bilirubin. So again, direct bilirubin is your conjugated bilirubin. Indirect bilirubin is your unconjugated bilirubin. So indirect bilirubin is your unconjugated bilirubin. Now, this is mentioned in your Harper's. Okay, intrahepatic, extrahepatic, and hepatic jaundice. So intrahepatic jaundice is exemplified by hepatitis or inflammation of your liver. So intrahepatic jaundice, a classic example is hepatitis. Posthepatic jaundice, this is known as your obstructive jaundice. The two examples mentioned in Harper's regarding obstructive jaundice, although there's tons of causes of obstructive jaundice, but the one found in our mother textbook is gallbladder disease or gallbladder stones and pancreatic carcinoma or pancreatic cancer. So posthepatic jaundice, classic example is obstructive jaundice. What are the two examples in your textbook? So we have gallbladder disease or gallbladder stones, and we have your pancreatic cancer. Now, please remember this. In the Philippines, schistosomiasis is a common cause of obstructive jaundice. So what is the etiologic agent of intestinal or gastrointestinal schistosomiasis? It's your schistosoma japonicum. Okay, your schistosoma japonicum. Gallbladder stones can also cause obstructive jaundice. Now here, let's go back to this. This is the figure which is lifted from your textbook. So we have prehepatic, which means before the liver, that's occurring in the blood vessel, so that's vascular. Hepatic, which means this involves the liver itself. Posthepatic is now beyond the liver, which means the biliary system and the pancreas. So the examples in this figure in Harper's, prehepatic or vascular is hemolytic anemias. Under hepatic or liver, we have liver diseases such as hepatitis and liver cancer. Posthepatic, which means it's already after the liver. That's the biliary system and the pancreas. Examples, gallstones and pancreatic cancer. Okay, so gallstones and pancreatic cancer. Now, please take note of this. Okay, I got this from some USLME forums. Okay, for direct hyperbilirubinemia. So direct DR. So the DRs are examples. The diseases DR are direct. Okay, so direct hyperbilirubinemia, this would be Dubin-Johnson and your Roeder syndrome. So Dubin-Johnson and your Roeder syndrome. Being Dubin-Johnson, then we have your Roeder syndrome. Dubin-Johnson and Roeder syndrome. So please take note of this. I'm not sure if you noticed in Dubin-Johnson, what's the color of the liver in the slide? It's black. So Dubin-Johnson presents with a black liver. Look at the color of the liver and rotor. It's not black. In other words, the liver color is normal. Now, if you notice, at the right side of the black liver is MOAT. Okay, your CMOAT. What is CMOAT? So I'll explain that next. Okay, so what is CMOAT? CMOAT. CMOAT stands for canalicular, multispecific organic anion transporter. Again, canalicular, multispecific organic anion transporter. So mutation of CMOAT, your canalicular, multi-specific organic anion transporter, leads to defective direct bilirubin or conjugated bilirubin excretion. This leads to Dubin-Johnson, that's the black liver, and Rotor syndrome. The liver is not black. So please memorize this. CMOAT, canalicular, multi-specific, organic anion transporter. Okay. So please take note of this. We're almost done. Okay, now, so black liver, is this Dubin-Johnson or is this Rotor syndrome? It is Dubin-Johnson. Okay. Now, conditions classified as isolated, conjugated, hyperbilirubinemia. So isolated, conjugated, hyperbilirubinemia. Now, always remember, conjugated is direct bilirubin. So we have Dubin-Johnson and we have Rotor syndrome. Now, there is a specific gene protein mentioned in Harper's, which is associated with Dubin-Johnson syndrome. This is your MDR2 protein. Again, MDR2 protein. Rotor syndrome is caused by defective storage of bilirubin in your hepatocytes. Now, take note, both Dubin-Johnson and Rotor syndrome are benign conditions. They don't require any specific treatment. Now, this is the one lifted. Okay, this is the one lifted from your textbook. Okay. MRP2. So what does MRP2 stand for? It stands for multi-drug resistance like protein 2. When there is a deficiency of your MRP2 or your multi-drug resistance like protein, this leads to Dubin-Johnson syndrome, which is a benign autosomal recessive disorder, which presents as conjugated hyperbilirubinemia. If you have your Harper's 31st edition next to you, or you have time to read it, and that will be your second reading, theoretically, you'll be in a better position than someone who just studies test papers or doesn't even open the book. So MRP2, multi-drug resistance like protein 2 deficiency. Dubin-Johnson syndrome, a benign autosomal recessive disorder, which is associated with conjugated hyperbilirubinemia. Now, last diseases, Crigler-Najjar syndrome. Okay, there's type 1. There is also type 2. Okay, so let's start with the type 1. Crigler-Najjar syndrome type 1 is also known as congenital non-hemolytic jaundice. This is a rare autosomal recessive disease which presents with severe congenital jaundice. Now, the definition of severe congenital jaundice is when you have kernicterus or bilirubin levels more than or in excess of 20 milligrams per DL. Bilirubin, more than 20 milligrams per DL. Now, please take note, it is stated in our textbook that mutations in the gene which encodes your bilirubin UGT activity is linked with your Crigler-Najjar syndrome type 1. Now, memorize this by heart. Crigler-Najjar syndrome type 1 is a fatal disease. Compared to type 2, Crigler-Najjar type 1 is the one that causes death. And death usually occurs within the first 15 months of life. In the first 15 months of life. Okay? Now here, Crigler-Najjar syndrome type 2, another rare autosomal recessive disease, also mutations in genes involving your bilirubin UGT activity. Compared to type 1, type 2 is more benign and the bilirubin levels do not exceed 20 milligrams per DL. Definitive treatment for Crigler-Najjar type 2 is phenobarbital. And I'll explain what phenobarbital does before we wind up this session. So please take note. Type 1, type 2, which is fatal. Type 1, which is benign. Type 2. Okay, now here, zoom into this. So we mentioned earlier, DRs are direct. So direct hyper. Bilirubinemia is Dubin-Johnson and Roeder. Then take note of this mnemonics. Interest can grow. So in, that's indirect. That's can grow. Letter C, that's Crigler-Najjar. Type 1 and 2. And letter G is Gilbert's syndrome. So in Crigler-Najjar syndrome, UDGT activity is absent. That's why it's fatal. In Crigler-Najjar type 2 as well as Gilbert's, there's still minimal UDGT activity. That's why the patients do not die. Okay? So I'm going to end with the last slides. So I got this from a biochemistry reviewer. So I want you to look at the numbers. Number 1, Gilbert syndrome. What is the problem in Gilbert syndrome? It's bilirubin uptake. Number 2, Crigler-Najjar. What is the problem with Crigler-Najjar? It is conjugation. Number 3, Dubin-Johnson. The problem is intracellular transport. Roeder syndrome, the problem is also intracellular transport of bile into the bile canaliculi. Okay. Now, this is the last thing I'm going to teach you, kernicterus. Kernicterus is also known as bilirubin encephalopathy. Now, always remember this. Bilirubin is toxic to the brain. It can cross the blood-brain barrier and it has special predilection. It has special predilection. Okay, it has special predilection to the basal ganglia of the brain. Now, for you to have icteric sclerae, or the yellow eyes, bilirubin levels should be 2 to 3 milligrams per DL. Once you have bilirubin levels as high as 15 milligrams per DL, you will now require phototherapy or photoisomerization. Once it's 20 milligrams per DL or more, then this is already kernicterus. You can have seizures, you can have decreased sensorium, you can have lethargy, and you can even go or slip into a coma. So this is icteric sclerae, okay, the yellowish discoloration of the sclera. What's the bilirubin levels? 2 to 3 milligrams per DL. Now here's a jaundiced baby. Okay, it's icteric sclerae plus the skin. So You obviously know that the levels of bilirubin are at least 2 to 3 or more. So white arrows, pay attention to the white arrows. This is a sagittal section of the brain. What's being pointed? Those yellow pigments at the tip of the arrow. Okay, that's the basal ganglia. Those dark pigments, that's bilirubin right after the tip of the arrow. Those dark pigments is bilirubin. Has special predilection to the basal ganglia, and that's the reason why the patient can present with seizures. They can also present with movement disorders like chorea. They can present with chorea. So lastly, what is the treatment for kernicterus? So this is the explanation for phototherapy. So mechanism. One is geometric photoisomerization of unconjugated bilirubin. And once unconjugated bilirubin is exposed to light, whether it's direct sunlight or in the hospital setting, they use the UV lamps or the phototherapy, your unconjugated bilirubin, okay, take note, which crosses the blood-brain barrier, will now be converted to an structural isomer known as lumirubin. Now, the prefix lumi means luminescence or light. And this is the process of photooxidation and photoisomerization. So this will explain why preterm babies who are jaundice, okay, they have pathologic jaundice. So always remember, if jaundice appears within the first 24 hours of life, if jaundice occurs within the first 24 hours of life, this is pathologic jaundice. So here's an example picture showing you phototherapy, okay, usually seen in the neonatal or nursery ICU. And lastly, the treatment, the therapy. So pharmacologic treatment, so drugs. Number one is your phenobarbital. The mechanism of action of phenobarbital in the treatment of your hyperbilirubinemias is induction of your glucuronidase transferase activity. Therefore, induction of glucuronidation. Therefore, the hepatic uptake of bilirubin is now enhanced. But take note, if you have a porphyria, phenobarbital is contraindicated. And lastly, for the pharmacologic therapy, we have your metalloporphyrins. Metalloporphyrins, mechanism of action, it inhibits heme oxygenase. So it inhibits heme oxygenase. Metalloporphyrins. So I hope everyone will take time to review those enzymes: heme oxygenase, biliverdin reductase, glucuronidase transferase. These are sure balls in any written examination. Okay, so your major reference will be Harper's Biochemistry. I also took from Robbins' Pathologic Basis of Disease, 9th edition. So with this, I'm signing off. I hope everyone learned something. Hit your books. Keep your eyes on the goal. God bless and keep safe, everyone. Thank you.